This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
So I've been given the pleasure of talking about family escalation. We have had some experience in Canberra. And I guess one of the reasons we started to focus on families was that it seemed to us that at times the people who were caring for patients on the wards were unable to recognise just that the patient was deteriorating. I must admit, I'm wondering whether in fact this is the case and whether in fact what's happening is a lot of normalisation of abnormal numbers, and often intensive care does not help that. So only last week we had a case whereby intensive care came along at least 2 or 3 times and discharged the patient from our care on the wards as part of the ICU outreach. And then, of course, the ward staff are paralysed that intensive care has said no, so surely the patient must be okay. And it's in those situations that probably the cleaner could spot that the patient was deteriorating rather than the clinical staff. And it was certainly of concern to me when I was in the intensive care unit 2 or 3 years ago now, when I saw a local barrister pop through the door, as they do, and I'm thinking, what on earth is he doing here? And we started chatting, and he had a friend who was in the intensive care unit. And this was the very patient, in fact, if you were here earlier, that I was talking about, whereby the specialist outside the intensive care unit was getting into a taxi and couldn't talk to me about the patient. This is a patient who had been deteriorating clearly for some days, but the clinical staff hadn't recognised it, or at least seemingly hadn't. And yet, this barrister, who is not medically trained, who doesn't do medical legal work, said to me, you know, he was getting really bad 2 days ago. So how was it that 2 days ago he was not in the intensive care unit? So you start to think, well, hang on, we need to provide systems that actually uses all care, all triggers to embrace the patients who are then appropriate for intensive care. So hence, family escalation. Now, for those of you who have mothers, some would be fortunate to have them, some would be unfortunate, but mothers seem to know best, and certainly mine often does. But the reasons that we sort of put to families and carers being part of the process is that they do know us best. They have lived with us for years, or at least have known us for years, and know the state of how well or not well we are. So long term they know us. And if you're lucky enough to have family and carers by your bedside, and I would urge you all to have family or carers by your bedside, because they can be your eyes and ears, that they will be there longer than the shift workers. And now, of course, these days, everybody who works in the healthcare organisation pretty much is a shift worker. So you get intermittent sort of capture of data. So you don't have the continuum that the families and carers do by the bedside. So if anything, they will know more about the picture. And certainly when I'm in the intensive care unit and the family is by the bedside doing my ward round, I will actually ask them first as to how they think things are going, because they know, I think, in the continuum what the picture actually looks like. So I do think that the families and carers have a role in, I guess, watching their loved ones and see whether things are getting worse or not. So, you know, our local example, which sadly seemed to have been repeated only just last week, and it's because this family were very much part of implementing our own family escalation system. And I'm sure you will have heard me talk about this case before. So not her real name, but Alice was a 17-year-old who came to our organisation actually a couple of times, eventually got admitted to the ward, unfortunately on a Saturday night, which then you can start to see why problems started to arise. She was 17 but got sent to a paediatric ward again, the wrong vital signs, if you like. So she had very high respiratory rates, but the paediatric staff weren't seeing that as abnormal. She had 22 medical reviews, multiple nursing reviews, and although fulfilled MET criteria, no MET came to see the patient. Now, the patient was seen by intensive care, but again, discharged because she wasn't sick enough. And then, of course, eventually got admitted to intensive care and had a long stay of multi-organ failure. One of the reasons I highlight this case is the mother, who some of you may have heard, has spoken about her experience of these 36 hours, or however long it was, short number of time, but multiple reviews, where she just felt completely powerless, that she kept seeing people come in and out, never talk to her about what was going on, or seemingly not talking to her, certainly not to the point that she understood what was going on. And I guess this family, for us in Canberra, have been instrumental in us finally getting a family escalation system up and running. But of course there are many cases around the world, and just to describe some more, that are local and international. So again, there's a case in Western Australia that I'm sure those of you there will know about, but the coroner says that it would have been helpful if more regard had been paid by staff to the family's opinion that the condition of the deceased was deteriorating. So we're not listening. I mean, I guess we have training that we listen to parents, paediatrics sometimes, but certainly doesn't seem to be promulgated in the adult world. So a local issue. Then Mike DeVito already spoke about this case. You know, Josie King, who was 18 months old, had burns, and seemingly died of central line infection. So in fact, she's been the driver of two patient safety items, both in terms of getting a family escalation system going at Johns Hopkins, but also very much a driver of why we have the checklist when we put central lines in, which has been very much driven by Peter Pronovost. But Sorrel King has said that if I had been able to call a rapid response team, I believe Josie would be here today. So very much about, if she had had the opportunity to escalate care, she thinks that there would have been a better outcome. And as such, Johns Hopkins now has this so-called condition H, whereby families can trigger a rapid response team. Again, in South Carolina, another event whereby, in fact, there's some legislation stating that families can have access to escalating the care of their loved one. So that's sort of, an international stories in terms of what has triggered family escalation pathways. And if we then look to see what in fact has been implemented and what do they look like, there are both, again, international and local examples. So if we go to Royal Berkshire, there's a call for concern, so C for C. They started out looking at patients who were discharged from the intensive care unit as part of their pilot. They had to use routine communication pathways, so that getting the ward staff first to see if they could reach some consensus to whether they should intervene or not. And then if they didn't get any joy out of that, then they could escalate the care and call the critical outreach nurse. And so again, they would then intervene to see what could be improved in terms of patient care. And then as part of the evaluation during that 6 months, I think everyone's very frightened that when you implement a family escalation pathway, that you're going to get this torrential pour of calls derived from families. And it certainly doesn't seem to be the case. In a small pilot study, which was done a few years ago now, 147 patients transferred out of the intensive care unit and only 12 C4C calls. And then because of the success, that is, it wasn't a whole series of calls, and it seemed to have prevented at least 2 cases of further clinical deterioration. It's now been rolled out, and on average, about 5 calls per month. But you'll see that, in fact, there's a low percentage of them needing clinical intervention, and many of them are around communication issues. I can't imagine why there are communication issues in healthcare systems these days. But seemingly, intensive care can fix everything, including communication issues. So that's in Berkshire in the United Kingdom. I guess leading from the work internationally and understanding the local scene, as has been alluded to, the Australian Commission on Safety and Quality in Healthcare developed this consensus statement looking at responding to and recognising clinical deterioration, and as part of that has included elements whereby families can escalate care. So although it's not one of the mandated items at the moment in accreditation, I'm sure it will be in the next version, whereby every healthcare organisation in Australia who wants to be accredited will need to be putting in place a family escalation pathway. So there is some impetus these days to include the families as part of the escalation process. So in Australia, and I think I certainly haven't covered all the jurisdictions. I see that there's a talk later on looking at the Queensland model, but just to describe a couple of them, and one, of course, including our own in Canberra. So this is a New South Wales system, the REACH, essentially trying to allow a family a pathway to escalate concern, but it's through the usual communication channels to start with, and then if they're still concerned, then, of course, they can actually call for a rapid response team. So that's certainly in the New South Wales system. I'm aware there's some other systems, certainly in Queensland and other places. So if we then go to the Australian Capital Territory, of which Canberra resides, we have implemented what we've called a call and respond early for patient safety, so the care call. So this allows us to use current communication pathways, that is using ward staff, and I'll show you this system in a minute, but it allows families to go through that pathway, and if they're still not getting any joy, then they start to call someone who is more critically care trained and then can initiate further intervention if needed, so the care call. So this is just one of our brochures that is given to families on admission. I think the challenge that we found is that once you start implementing a system, you realise there are other systems that are not working. So I'm not sure what your organisation is like and how many pamphlets your patients are receiving, but it seems to me that you get a whole wodge that just gets landed onto your bed and kind of, here you go, get on with it. And then, of course, the other challenge was not only the wodge of brochures, but also the fact that each ward did it differently, and whether it be the ward clerk or the bedside nurse or someone else, there was again differences between each ward area. So there was no unified way of actually systematising this, and I think this has actually driven some other changes. That is, we've now trying to make the information going to patients as uniform as possible, and including the care process as well. And hopefully someone would actually talk to the patients and families about the care pathway. But again, I'll show you some information that may not be happening. So in the first instance, they are calling the bedside nurse who's caring for them. If they get no joy there, then they go to the nurse in charge. And again, if they get no joy there, then they can call the care phone. And the care phone through Monday till Friday, actually during working hours, is carried by our Met nurse, and after hours is covered by the most senior nurse in the hospital, who also has some critical care skills as well. You'll notice that right at the top, we've now, what was not present to start with, are you concerned about the patient's medical condition? I still think that's not in large enough letters, because you'll see later that the calls that we are getting are not necessarily related to medical condition. So that's certainly our pathway anyway. Now, to try and work out whether this is working or not working, it's not only about the number of calls that we get, but also that we go and talk to the families who have escalated their concerns and how they have perceived the usefulness of it or not, but also surveying the staff and the families who are present on the ward at that particular instance as to whether they've actually heard about it and how have they heard about it. So if you see over the last 2 financial years at least, over 12 months, we're getting around 40 calls per year. So it is not deluging the system, which you may see as an issue. But certainly in our own organisation, if you just look at the Met calls made, only 4% are delayed. So you may sort of think, well, maybe we have not got an issue with recognising patient deterioration, so maybe that's why families are not using the system, because already our patients are being picked up by the physiological triggers and the calls for concern by staff. You will see that the vast majority are coming from the surgical wards, so unlike the Met system happening in the sort of medical areas, it seems to me that the calls are coming from the surgical families. And mostly it's about delayed admission to the operating theatre. I can't imagine that happens elsewhere. So the challenge that we find is that a very, very, very small percentage of these calls are about clinical deterioration. And you can either see that as a good thing, that we've already picked these patients up, or is it that we just have no idea whether there are patients out there who are deteriorating, who the families, for one reason or another, feel unable to call for help. The other issue, of course, is that we're getting a lot of complaint phone calls. I suspect this is the very precious Canberra population, and they do like to complain. But I think also it means that our complaints pathway is inadequate. It is not 24/7, which this process is, and so it's the number that they see that they can call for help other than clinical deterioration. And the bottom line probably is of the gravest concern of all, so that when we finally wonder whether patients are knowing about the system, in fact, less than half are knowing about the care system. And that's just despite putting posters and brochures on the wards, and in theory, that on admission, you're getting to hear about the family escalation system. And I think partly this is not unusual. I've certainly heard this happening in other organisations as well. Somehow the nurses either don't see, and of course the nurses say, why is it a nursing responsibility? And that's a very fair comment. But it's not seen as part of their role. In some respects, seeing it as a weakness of their own healthcare delivery system, so are not promoting it as a good thing to do. And indeed, when we go to talk to the family, well, how did you find out? Was it from the nurses? In fact, often it's from the posters that have been up on the wall as to how they found out. So all I can say to you is that, yes, we have rolled it out, but there are certainly a significant number of issues which are leading us to think further. But when we go to interview families who are aware of the system, they certainly don't seem to be afraid of calling the system, and there are other reasons why they might not call for help. But if we go back to the nursing staff and see, well, how did you feel, in terms of rolling out a family escalation system? On the whole, it was received positively. And I guess, it's kind of putting yourselves in the shoes of the patient and family, that you would also like a system so that if you had concern, that you could call for help as well. So maybe that's why they also think it's a good thing to do, because you never know when it might impact yourself. But as I said to you, in fact, I think we've now been running this family escalation pathway for about 3 or 4 years. We believe it's timely to reflect on whether this is actually what we were trying to achieve in the first place. It certainly has been a cultural change for our nursing staff. And have we got a system that really empowers patients and families to call for help? There is no doubt in my mind that if I wanted to call for help, I would really have to reach a level where I felt very confident that I'd got it right. In fact, I actually had my own little deteriorating patient about, 5 years ago at home, who was age 2, and I kept thinking, no, she's fine, she's fine. And then when I really thought, oh my God, I've now got my own deteriorating patient that I have not recognised. And when I took it to the emergency department, the senior nurse, this is in the middle of the night, and I was so grateful there was a very senior nurse. She said, oh my God, she looks sick. And I'm thinking, well, I'm glad I got it right, but now I'm really scared. So I just can see how much energy, activation energy, you need to call for help. So do we empower families and patients enough? And also I say, I'm not sure we've got the marketing right, the branding right, in that we are getting more calls about complaints and communication rather than about the medical condition. And on that note, I shall finish.